Welcome to the Center for Reproductive Medicine IVF Education presentation. We're going to be covering a few different topics today. We'll talk about who will care for you during your IVF cycle, how we communicate your plan and instructions, how to read your IVF calendar, appointments you will need, medications you will be taking, what to expect during your egg retrieval or embryo transfer, and risks associated with an IVF cycle. Any questions you have, please write them down as you go. Follow up through the patient portal or ask to speak with a nurse. We have a team of physicians at Center for Reproductive Medicine who take turns working the weekends and doing IVF procedures. Your primary physician has made your IVF plan, but other physicians will be involved in your care throughout your IVF cycle. Your primary physician may not be the one performing your egg retrieval or embryo transfer. Communication throughout your IVF cycle is going to be through the patient portal, so you have to be registered. All medication plans are sent via the portal. You will receive a portal message after every appointment. Messages are sent by 5 p.m. Please remember that portal messages sent back to us are not for urgent needs. Portal messages are only checked during normal business hours. If you have an urgent need after hours, we do have an on-call physician available, and the number is provided here. Your provider has chosen an antagonist cold start protocol for your IVF cycle. Cold start is our way of saying that you don't need to take any medications prior to your IVF cycle to prepare your ovaries. Some other protocols use medications to prepare the ovaries for different reasons, but your physician thinks you will respond best with a cold start. A cold start cycle begins with the start of your menses. Menses is another word for period. So your IVF cycle timing is dependent on your menstrual cycles. We will be covering the significance of antagonist medication in a few slides. You might wonder, how does the timing work if I have to wait for my period to start my IVF cycle? When you start your period, you will call the office on cycle day 1 to schedule a pre-scan for cycle day 2. Stimulation medications are started on cycle day 2 if the pre-scan looks good, and I'm going to be explaining what the pre-scan is looking for, as well as what the stimulation medications are in the next few slides. Since your protocol involves a cold start, the timing of your IVF cycle is completely dependent on when your period starts. We cannot provide an official calendar for your cycle until you start a period, and ultrasound and blood work show that it is safe for you to start IVF stimulation medications. There's an example calendar on the next slide for your reference. Let's take a look at that. This calendar is similar to what you will receive for your IVF cycle. There's a legend at the bottom that explains all of the abbreviations. There's a reminder every day to take a prenatal vitamin and vitamin D. These vitamins can be taken any time of day. Appointments are highlighted in yellow. Besides your pre-scan appointment, we can plan ahead for 3 monitoring appointments at the start of your cycle. Additional appointments will be needed, but the timing of these appointments is dependent on your individual response. Please keep in mind that the calendar is only a guideline, and as you progress through your stimulation, you may need to change or add appointments per the discretion of your medical team. There's a reminder to check medication inventory as you head into a weekend. This is especially important for those using a mail order pharmacy. The week highlighted in blue is your anticipated egg retrieval week. This is as specific as we can be at the beginning of your IVF cycle, as the actual timing of the egg retrieval is dependent on your individual response. All monitoring appointments for blood work and ultrasounds are scheduled in the morning before 10 a.m. on weekdays and before 9:30 a.m. on weekends at the Center for Reproductive Medicine. Your IVF pre-scan, ultrasound, and blood draw will be done on cycle day 2. This appointment determines if it's okay for you to start your IVF cycle. Your ovaries should be quiet, which just means that there are no large developing follicles, and your estradiol level should be low. If we see a residual follicle that's 15 millimeters or greater on ultrasound, and/or your estradiol level is elevated, you're at risk for having a suboptimal response with your IVF cycle. We want you to have the best response possible, so any of these findings may mean that we need to cancel your cycle and try again with your next period. Let's start talking about the medications used for an IVF cycle. Stimulation medication refers to the direct stimulation of the ovaries. These are large doses of hormones that are normally produced by the pituitary gland in the brain. In a natural cycle, the pituitary gland produces just enough to stimulate the ovaries to mature one egg for ovulation. In IVF, we want multiple eggs to mature for retrieval. The first stimulation medication you will be using is an injection of follicle-stimulating hormone, or FSH. There are 2 brands of this medication, Gonal-F or Follistim. We order the brand of medication that is either covered by insurance or cheaper at the pharmacy you've chosen to use. There's no difference between Gonal-F and Follistim. They could be used interchangeably. So these medications encourage the growth of multiple follicles. They are a subcutaneous injection. We're going to ask that you please refer to the freedommedteach.com videos for detailed instructions on how to prepare and administer a subcutaneous injection. This medication is taken in the evening between 7 to 9 p.m. Your first day of stimulation medication is considered treatment day 1. You will also see this noted on your calendar as TD1. The starting dose of this medication is determined by your pre-testing results. The second stimulation medication that you will be using is human menopausal gonadotropin. There's 1 brand of this, it's called Menopur. It contains equal amounts of follicle-stimulating hormone and luteinizing hormone. Luteinizing hormone is also very important for proper egg maturation. This is also a subcutaneous injection, and it's taken in the evening between 7 to 9 p.m. with your FSH medication. You may start this on treatment day 1, or you might start it on treatment day 4. This plan is individualized based on your pre-testing results. Side effects from your FSH medication and Menopur are the same. These are related to the effect that the medication is causing in the ovary. As your ovaries respond, they get much larger than normal, so you may feel abdominal fullness or pelvic heaviness. Your ovaries can be tender, especially with higher impact activity or intercourse. Your high estradiol levels may cause you to feel breast fullness or experience weight gain and water retention. There's also the possibility of ovarian hyperstimulation syndrome, or OHSS. We will address this in more detail on a later slide. After you have taken 3 nights of stimulation medication, you'll have your first monitoring appointment. This appointment will include a blood draw to check your estradiol level and an ultrasound to check your follicles. Estradiol is a measure of ovarian activity. As follicles are growing and maturing, they produce more and more estradiol. Ultrasound allows us to see the follicles on your ovaries so that we can measure and count them. Follicles start off less than 10 millimeters in size and typically grow by 1 to 2 millimeters per day. Ultrasound also allows us to assess your uterine lining, ensuring that it is growing thick enough throughout your cycle. If you started your cycle with your FSH stimulation medication only, you will start your HMG on treatment day 4. If you were looking at your calendar closely, you might have also noticed an antagonist medication noted on treatment day 4, but it has a question mark. The antagonist medication is very important for your cycle because it prevents premature ovulation. There are 2 brands, Ganirelix or Cetrotide. This is also a subcutaneous injection. We don't know if you're going to start your antagonist medication on treatment day 4. This medication can suppress the growth of follicles if it's started too early, before the follicles are actively growing. Our benchmark to start this medication is to see an estradiol level of at least 75 or follicles on ultrasound that are measuring at least 14 millimeters. Once we see those benchmarks, you'll start antagonist. So the antagonist could be started on treatment day 4, or it might not be started till treatment day 6 or 8. It just depends on your individual response. Once you've started your antagonist medication, every single monitoring appointment after that will include both an ultrasound and blood draw. Side effects of antagonist medication include a little reaction at the injection site, manifests as a little bit of redness or itching that resolves within 24 hours. You can also have headache, abdominal pain, or nausea. At the beginning of your cycle, we can plan for monitoring appointments on treatment days 6 and 8. All monitoring appointments will include both a blood draw and an ultrasound. At every appointment, a physician is making a determination about whether your medication doses need to be changed. After each appointment, it's possible that you may receive instruction to increase, decrease, or keep your doses the same, depending on your individual response. It is also possible that the timing of these appointments may need to be adjusted depending on your individual response. At this point of your cycle, you may also need to start thinking about reordering medications. It is your responsibility to keep track of how much medication you have left throughout your cycle. With the initial orders, we try and order enough to last you through 12 days of stimulation. That being said, if your doses are changed, then you're either going to have extra medication or not have quite enough for 12 days. If you're using U of M insurance, we're limited in how much medication we can order each time, so you will need to get refills more frequently. Your initial medication order included refills. This allows you to contact your pharmacy directly to arrange for pickup or delivery of additional medication as needed. You do not need to get a new prescription from us. You'll want to pay particular attention to your medication stock before weekends and holidays, as shipment or pharmacy hours may be limited at those times. Please remember to allow sufficient time. Check with your pharmacy to see how late in the day you can submit an order for overnight shipping to receive medication the next day. Most pharmacies are not open on the weekend, and so do not deliver on Sunday or Monday. Treatment day 9 and beyond. While not noted on your calendar, you will continue to need monitoring appointments after treatment day 8. The timing of these additional appointments will be determined based on your individual ultrasound and estradiol levels. You may need to start being seen daily, so a great deal of flexibility is needed. We cannot plan ahead for these appointments as everyone's cycle progresses differently. At this point in your cycle, we can typically tell whether or not you're having a suboptimal response to the medications. If a suboptimal response is seen, a physician will call to discuss options with you. If we're seeing 1 to 3 developing follicles with nothing else, they may talk to you about converting the cycle to an insemination cycle or trying timed intercourse, if that's appropriate for your situation. If it's not appropriate to do insemination or timed intercourse, they'll consider canceling the cycle outright. That being said, this is a discussion with you. We won't be making decisions without talking to you. If your cycle is canceled, your physician will discuss your outcome with our physician group team to come up with the best recommendations moving forward. That typically involves trying a different medication protocol with the future IVF cycle. If your cycle is progressing well, your last injection will be your HCG trigger shot. There is one brand of this, it's called Ovidrel. This is given when 2 or more follicles measure at least 18 millimeters in size. You may or may not take doses of your stimulation medications on the day of your trigger shot. It's a subcutaneous injection and is important for 2 reasons. It causes final maturation of the eggs and causes important changes which allow us to actually retrieve the eggs from the follicles. As the eggs are maturing during the cycle, they are stuck to the side of the follicles. Ovidrel releases the eggs so they are free within the fluid of the follicle. There's a very specific window of time when the eggs can be retrieved before they would be released from the follicles and lost. So Ovidrel is a very time-sensitive medication. Your egg retrieval will be scheduled 36 hours after you take Ovidrel. Around the time that you take your trigger shot, or within a week following your egg retrieval, you may notice symptoms of ovarian hyperstimulation syndrome, or OHSS. As we discussed in a previous slide, OHSS is a side effect of the stimulation medications. The majority of people who do IVF do not develop OHSS. You're at greater risk for OHSS if you have a robust response to the medication and have many follicles with a very high estradiol level. The large number of follicles and high estradiol level leads to fluid leaking into the abdomen or belly. There is a spectrum of symptoms from mild to severe. In mild cases, you have abdominal bloating and discomfort, but it resolves without medical intervention within a couple of weeks. In moderate cases, you have increased abdominal bloating, decreased urination and darker urine, vomiting and diarrhea, or possibly constipation. These symptoms may warrant monitoring with ultrasound and labs, and we may also ask you to weigh yourself daily. In severe cases, you have abdominal bloating up above the belly button, so the whole abdomen is swollen, a marked decrease in urination, shortness of breath, nausea, and vomiting. Severe symptoms occur in less than 0.2% of cycles. These symptoms will warrant monitoring with ultrasound and labs and may even warrant treatment or hospitalization. If we think you are at increased risk for OHSS based on your ultrasounds and estradiol levels, there are measures we can take to prevent or minimize any symptoms you might have, including decreasing stimulation medication doses to slow your response, or additional medications around the time of your egg retrieval to help suppress your hormone levels following your egg retrieval. If you're planning on an embryo transfer after your egg retrieval, we may recommend freezing all of the embryos to allow your body to recover from OHSS. Hormones released in pregnancy can worsen symptoms of OHSS, making you a lot sicker. It's also possible we may change the type of trigger shot you use, as the HCG in an Ovidrel trigger shot will also worsen the symptoms. Once you have been given instruction to take your Ovidrel, we need to think about the sperm source. If you're planning to use a fresh ejaculate sample, your partner should refrain from any sexual activity, including masturbation, from the day you take Ovidrel until the day of the egg retrieval. Your partner will be asked to collect a specimen either before, during, or after the egg retrieval. If you have a previously frozen sperm sample or are using a frozen donor sample, it will be thawed the day of your egg retrieval. If your partner sees a urologist and a fresh testicular aspiration is planned, the aspiration will be scheduled per the urologist's recommendation, either the day before or the morning of the egg retrieval. Let's talk more about your egg retrieval. The technical term for this is transvaginal oocyte retrieval, or TVOR. As I said before, it's scheduled 36 hours after Ovidrel is taken. Egg retrievals are performed in the morning at Center for Reproductive Medicine, our Briarwood office. You'll be asked to arrive sometime between 6:30 and 9:30 a.m. in most cases. We take into account many factors when scheduling your egg retrieval appointment, including the number of follicles you have and your fertilization plan, as well as all the other procedures happening that day. This ensures the safety of eggs and embryos in our ART lab. Please understand we cannot accommodate individual scheduling requests, and once your appointment time is given, we cannot change it. When you come in for your egg retrieval appointment, you'll meet with the physician who will be performing your procedure, as well as the anesthesiologist who will be doing your sedation. The physician will go over a consent for your procedure and talk about the risks, and the anesthesiologist will do a quick preoperative assessment, start an IV, get you hooked up to a cardiac monitor, give you a little oxygen, and help you get positioned on the table. Once everything is in place, they'll start deep sedation. We use propofol, Versed, and fentanyl to achieve this. means that you'll be asleep, having a nice nap while the egg retrieval is being done, and you'll wake up fairly quickly. While you're asleep, we do an ultrasound-guided needle aspiration. This is a transvaginal ultrasound probe with a needle guide attached that goes into each follicle and aspirates or sucks out the fluid. All of the follicles that are accessible will be aspirated. It's important to know that sometimes the ovary is not positioned well for us to be able to get to it with the needle. There are techniques we can try to reposition the ovary while you're asleep, but there are cases where we just can't get to the ovary without puncturing through something vital. And we're not going to puncture through something that could harm you to get to a follicle. About 80% of the follicles that we can get to that are at least 15 millimeters in size will have an egg. About 80% of those eggs will be mature. We say this to highlight the fact that just because you have a certain number of follicles does not mean that you're going to have that many eggs. You will get notification of the number of eggs before you're discharged that day. Here's the diagram of how a transvaginal oocyte retrieval is done. You can see the uterus, fallopian tubes, and ovaries. The black circles within the ovaries represent the follicles. The ultrasound probe is within the vagina, and the needle guide attached to it allows the needle to puncture through the vaginal wall and into each follicle individually. Once one side is fully retrieved, they'll switch to the other side and retrieve the follicles from the other ovary. There are risks associated with an egg retrieval. There's a risk that you may not respond well to the anesthesia. You could have bleeding, infection, injury to the ovary, or injury to other organs in the pelvis. There's also the chance that we don't get any eggs for some reason, or that the sperm sample is not adequate for fertilization. Recovery following your egg retrieval takes 30 to 60 minutes. Your judgment is impaired after you have sedation, so you'll be discharged home with an adult driver you know and trust, and you must take the rest of the day off. You can expect to feel mild to moderate discomfort, kind of like period-type cramping, and a small amount of vaginal spotting. Fertilization is done in the afternoon after your egg retrieval. As I said before, about 80% of the eggs we retrieve will be mature. An egg must be mature to be able to fertilize. There are two methods of fertilization, IVF and ICSI. Conventional IVF is where the egg and sperm are put in a petri dish together, but the sperm is allowed to penetrate and fertilize the egg on its own, as it would inside of the body. With ICSI, this stands for intracytoplasmic sperm injection. A single sperm is injected into the egg. Once fertilization is done, petri dishes are incubated in strictly controlled conditions. Fertilization will be checked the next morning when they can look under a microscope and see normal structures of fertilization. The day after your egg retrieval, when fertilization is checked, is considered day 1 of embryo development. Updates are given on day 1, day 3 if your plan is for a fresh transfer, and day 5 or 6 of development. Risks here would be that we don't have fertilization for some reason, or the embryos fertilize but stop developing at some point. This is considered arrested development. This slide gives an example of attrition that can happen at each stage. This is not a hard and fast rule. I don't want you coming out of this thinking that you need to have at least 15 follicles to get 2 blastocyst embryos, but it's an example of how there's loss at every stage of the IVF process. For example, you have 15 follicles developing. Of those 15 follicles, not every one yields an egg. So maybe we get 12 eggs from the 15 follicles. Of the 12 eggs, we don't expect all of them to be mature. So maybe we get 10 mature eggs that are able to fertilize. Having a mature egg does not guarantee that it will fertilize. So in this example, we have 7 eggs that fertilize. Of the 7 that fertilize, 2 have arrested development and do not continue to develop. So we have 5 good quality embryos on day 3 of development. Once again, arrested development can happen after day 3 of development. So in this scenario, we end up with 2 blastocyst embryos on day 5 or day 6 of development. In 1 to 3% of IVF cycles, we won't have any embryos develop, in which case there's no embryo available for transfer or testing. Whether you are planning a fresh embryo transfer, meaning a transfer that occurs 3 to 5 days after your egg retrieval, or a frozen embryo transfer, which means an embryo transfer that occurs in a separate cycle of an embryo that's been frozen, you will use the same medications to prepare the uterine lining. Estradiol is a hormone that builds and maintains the uterine lining. Progesterone is a hormone that changes and supports the uterine lining, making it receptive to an embryo implanting. Medrol is a steroid that lowers the body's defense mechanisms to enhance the chances of implantation. For a fresh embryo transfer, you will start those medications after your egg retrieval. You'll have tentative transfer appointments for day 3 and day 5 of embryo development. The decision about which day to do your embryo transfer is based on the quantity and quality of embryos that you have. The embryologist will take a look at your embryos on day 3 of development, and a physician will call with an update and recommendation of which day to do your embryo transfer. The number of embryos we transfer is based on ASRM guidelines. Any extra embryos are frozen if and when they reach blastocyst stage on day 5 or day 6 of development. If your plan includes pre-implantation genetic testing, or PGT, the biopsy will be performed when the embryo reaches blastocyst stage on day 5 or day 6 of development. Embryos are frozen once they're biopsied, and the frozen embryos do remain in our lab. The biopsy samples, however, are sent to an outside lab for the testing. Results are typically received 7 to 10 days after the biopsy samples are sent. Once we receive the results, we can make a plan for your embryo transfer in a future cycle. When we've done testing of the embryos and know that they are chromosomally normal, or euploid, we will only transfer 1 embryo at a time. Whether you are planning a fresh embryo transfer or a frozen embryo transfer, the procedure itself is the same. It's going to feel similar to your mock embryo transfer. You need to have a full bladder. One big difference between your mock embryo transfer and your actual embryo transfer is you will take Valium an hour before your actual transfer. This isn't meant to sedate you at all, although that's one of the effects, but the primary reason we have you take Valium is to help keep all of your pelvic muscles relaxed and minimize cramping that you have during the procedure. Because of the Valium, once again, your judgment is impaired, so you cannot drive yourself, and you must have an adult driver that you know and trust who can bring you to and from the appointment. You should not plan on returning to work that day. Other than that, there are no activity restrictions. Risks here would be that we have a difficult or failed transfer. We do our best to head off issues with the transfer by doing a mock embryo transfer ahead of time to identify any issues getting through the cervix. But that's not a guarantee that we won't have difficulty the day of. After your embryo transfer comes the long wait for your pregnancy test. If you have a day 3 embryo transfer, it's a 12-day wait. If you have a blastocyst stage embryo transfer, it's a 9-day wait. So 9 to 12 days after your embryo transfer, you'll have your blood drawn for a beta-HCG level. That's the pregnancy hormone. There's 3 things we might see with this level. The first is a strongly positive result. In this case, you would continue your estradiol and progesterone support and repeat the level in 2 days. In some cases, we see what we would consider a low positive result. This means that the level is positive but doesn't quite meet our benchmark for the first level. In this case, you would continue your estradiol and progesterone support and repeat the level in 2 days to see whether it's rising or falling. You may need further blood draws beyond this. There's also the possibility that we see a negative result. This means that the embryo did not implant. In this case, you would stop estradiol and progesterone. You'll start a period after stopping those medications, and then have a return visit with your physician to discuss next steps. With a positive pregnancy test and appropriately increasing beta-HCG level, you'll continue your estradiol and progesterone support until 10 weeks gestation. At this point, the placenta has taken over hormone production completely, and the additional medications you're taking are no longer needed. We'll get you scheduled for an ultrasound at 7 weeks gestation to check on the health of the pregnancy. We can confirm that the pregnancy is truly located in the uterus. We can confirm or rule out multiple pregnancy, and we can check for normal structures of early pregnancy, including a gestational sac and a yolk sac. At this stage, we can also see what we call a fetal pole, which is the tiny embryo developing. The first organ to develop and start functioning is the heart. So at 7 weeks gestation, we can actually measure cardiac activity. Once we see all of these different things with your pregnancy, see that it's healthy, you graduate from our care and establish care with an obstetrician or midwife, whoever you want to see throughout your pregnancy and delivery. We get a lot of questions from people as they go through their IVF cycles. And I'd like to address a few of the common questions that we get here. The first is whether or not exercise during your IVF cycle is safe. It definitely is, but your IVF cycle is not the time to introduce a new strenuous exercise routine. Anything you have been doing, you can continue to do as long as it's not causing discomfort. As your ovaries grow larger and larger, they may become tender and uncomfortable with higher impact activities. If you're having pain or discomfort, then dial back your activities until you're comfortable again. We also get questions about whether or not there's a specific diet that can help increase the chance of success. There is no scientific data that shows one diet is better than another for success with an IVF cycle. There are many vitamins and supplements that are marketed to help with fertility. Unfortunately, there's not great regulation of these vitamins and supplements. There are very few supplements that we may recommend during your cycle. So if it hasn't been recommended by us or another physician, then please don't take it. Alcohol is safe in moderation during your IVF cycle. You can have a drink here or there. The day of your egg retrieval, because of the sedation that you'll receive, you should not have any alcohol. Caffeine is also safe in moderation. Intercourse is safe during your IVF cycle, but may become uncomfortable as your ovaries get bigger. There's also the chance that we won't retrieve every single egg with your egg retrieval. Any unretrieved eggs will ovulate. If there's the chance that sperm could meet up with the egg, then that could result in a multiple pregnancy. Because of this, we recommend abstinence or a barrier method of contraception like condoms 2 weeks before and 2 weeks after your egg retrieval. There is no need for bed rest after your egg retrieval or embryo transfer. Travel and flying is safe after your embryo transfer, but you really can't travel during your IVF cycle. You have to come in for such frequent appointments that it just wouldn't work out. To complete your IVF education, please watch the medication teaching videos at freedommedteach.com. You can find a list of assigned videos in the portal message we sent you. You will also need to read through your IVF consent. A copy is included in your IVF folder. Once you have watched the videos and read through your IVF consent, please follow up through your patient portal or call the office with any questions.